On behalf of the Patient Safety Authority, I would like to welcome you to this webinar titled Antibiotic Stewardship Webinar Series, Antibiograms. My name is Amanda Bennett, and I will be your moderator for this program. All materials are provided for your educational use. Now I'd like to introduce our speaker for the webinar. Christine Bingman is an Infection Prevention Advisor for the Patient Safety Authority. In this role, she is responsible for education and outreach for infection preventionists at all levels of healthcare. Christine has clinical infection prevention experience as an infection preventionist and a manager of infection prevention for a large health system, as well as a director of infection prevention in acute care, behavioral health, long-term care, hospital-based clinics, ambulatory surgical sites, and long-term acute care facilities. Her clinical experiences enable her to assist others in setting priorities for patient safety and to serve as a content expert in developing infection prevention strategies and solutions for our healthcare partners. Christine, I will now turn the program over to you.
Thank you so much, Amanda. Welcome to those who are joining us today for this episode of Antibiotic Stewardship and Antibiograms. The objectives for today's session, upon completion of this webinar, is to be able to describe an antibiogram and its purpose, list the required data to create an antibiogram, and then explain the process to interpret an antibiogram. First, just a reminder about why we are focusing on limiting the use of antibiotics and the potential negative outcomes. So when we look at the use of antibiotics in long-term care, there's an annual prevalence of about 47 to 79%, and this is fairly high. And the literature shows that more than half of those medications prescribed are not even indicated. We continue to have inappropriate prescribing, so wrong drug, wrong dose, and incorrect duration. We obviously have some negative outcomes from the use of antibiotics, and this includes C. diff, adverse drug events, the drug-to-drug interactions, and then also the main reason, the development of antimicrobial resistance. So again, just to review some of the terminology that we will encounter in this particular webinar, antibiograms. This is a methodology to assess the antimicrobial sensitivity information within your organization and is used to monitor emerging trends related to resistance. We will be using susceptibility reports, and so we wanted to have a good understanding of breakpoints, and the breakpoint, the MIC or zone size used to differentiate between susceptible, intermediate, or resistant susceptibility results. Susceptibilities are a form of testing that is used to determine the effectiveness of specific antibiotics. Bacteria are susceptible when it is unable to grow in the presence of one or more antimicrobials. Resistance is the ability for bacteria to grow uninhibited in the presence of antimicrobials. And intermediate bacteria are able to grow uninhibited unless the antimicrobial concentration is higher or the frequency of antibiotic administration is increased. So again, we want to discuss minimum inhibitory concentration, and this is the lowest concentration of an antimicrobial that will be effective to inhibit growth. The numeric value is in micrograms per milliliter of an antibiotic that inhibits the growth of a strain of bacteria. Next to the MIC is a susceptibility interpretation, sensitive, intermediate, and resistant. or resistant. Sensitive implies the organism is inhibited by the serum concentration of the drug. Intermediate implies that organisms are inhibited by the maximum recommended dose. And resistant means the organisms are resistant to the usual achievable concentration of drug levels. An additional term that we need to be familiar with for the purposes of antibiograms is empiric. So these are antimicrobial agents given to a resident with signs and symptoms of an infection prior to the availability of culture results. It is based on the likely pathogen, the site of the infection, and your aggregate summary or antibiogram for your institution. So what does a cumulative antibiogram show you or tell you? So it monitors trends in emergent drug resistance within your facility or maybe your local healthcare system. It enables you to determine what are the best antimicrobials for empiric antibiotic therapy. And then you can measure resistance changes over time in your organization. So updating a cumulative antibiogram, what information is needed to do this? Some institutions have the luxury of computer-based systems that enable them to create a rolling antibiogram with the assistance or the collaboration of the laboratory, the pharmacy, and infection prevention. But the majority of long-term care facilities are relying on the collaboration between the laboratory that serves their population and the pharmacist that serves your particular institutions. Antibiograms should be created annually and compared to the previous year's antibiogram. You only want to include diagnostic isolates. So you are looking for the first culture result or culture isolate from a resident with a particular organism. You only use finalized cultures. You have to, or it is preferred, that you have specimens with 30 or more isolates to be included in your antibiogram. If you have less than 30, there's the chance of some bias with that, those measurements. Only antimicrobial agents routinely tested should be included. So the laboratory usually has a set number or specific antibiotics that they're testing with organisms, and the routine ones should be included in your antibiogram. The laboratory should exclude the percent indeterminate. So on your susceptibility patterns, the ones that are indeterminate should not be used to create your antibiogram. You kind of probably already figured this out, that infection prevention, pharmacy, and the laboratory must work together to create that new antibiogram. And the most recently, the organization, the regulatory agency for laboratories, came out with a new set of recommendations. It is the CLSIM 39 recommendations for the collection, storage, and analysis and presentation of microbiology data. So this is what's guiding the laboratories to store and analyze your institution-specific antibiotic resistancy patterns. You want to exclude duplicates by including only the first isolate, regardless of body site or antimicrobial profile. So if you have a resident with a wound, from one site and they have a wound at another site, you're only going to use that very first isolate for that antimicrobial profile. So what data is used to create an antibiogram? So we are not going to use surveillance specimens. We only want clinical specimens to be included. You want quantitative MIC data, and this is information from your laboratory. You want a minimum of 30 clinical isolates for given pathogens. Only the first isolate from residents with multiple positive cultures. And then your intermediate susceptibilities are not included in creating your antibiogram. So again, only the first isolate from residents regardless of body fluid sources. An exception to the rule, there's always an exception to the rule, is for penicillin intermediate susceptibilities for the organism Streptococcus pneumoniae. So the proportion susceptible to specific drugs are used and usually documented for meningitis and non-meningitis breakpoints. And the laboratory and your pharmacy will include that information in your antibiogram. So how do we interpret an antibiogram? So this is just a very small antibiogram with a select number of organisms. You typically see your gram-positive organisms, a lengthy list, and then also that long list of gram-negative organisms, and some organizations will also print or provide your fungal organisms and resistancy patterns for those organisms. So when we look at this, there on the far left are the actual organisms, and next to that are the number of isolates. So if we focus on the gram-positive organisms, we can see that the number of isolates listed 47, 35, and 38. This is an adequate number of isolates and will give you good statistical information as to the resistance patterns for these particular organisms. So when you go across the row, you have your pathogen or organism, and then in the columns, you have your normally used antibiotics for those particular organisms. And then as you go across the row and down the column, you're going to see a numeric value, or you may see dashes. So the numeric value is the percent susceptible. So this is the number of susceptible isolates divided by the total number of isolates tested and then multiplied by 100. So when we look at Staph aureus, we have 50% susceptibility with clindamycin. If we go across to linezolid, we have 100% susceptibility for treatment for Staph aureus. When we're determining what antibiotic we want to select, obviously we don't want to go with the big guns to treat our residents, otherwise we are going to develop resistance. We want to choose an antibiotic that has at least an 80% or higher susceptibility to that particular organism. And again, you will see that some antibiograms will have further definition or defined breakpoints for certain organisms, or maybe the antibiogram will include isolates for urinary tract infections versus all infections, and we'll see an example of that here shortly. If we drop down to the gram-negative organisms, we see that the number of isolates, 36, and then the number 19, which is lower than 30, and this indicates less than 30 isolates and potentially low accuracy for susceptibility rates. Again, you want to have higher than 32 isolates in order to give you statistically significant results. So again, looking at E. coli, ampicillin is 88, and we go across, and tetracycline is only 24. So this is 24% susceptible to this particular organism. Based on this result, this is not an antibiotic that would be our first choice to treat an infection with E. coli. But anything above 80% is an antibiotic that we would wish to choose. If we look at Proteus mirabilis, this is an organism that we often see in urine cultures. Again, we have 32 isolates, and if we go across, we have tetracycline, again, low at 18%. So this is not an antibiotic that we are going to choose to treat an infection with this particular organism. We want the ones that are greater than 80%. So ampicillin, gentamicin, linezolid, the TMP SMX. This is where we want to, this is an antibiotic that we would choose to treat this particular infection. So again, just highlighting some of the exceptions to the rule. So Streptococcus pneumoniae and ceftoxime and ceftriaxone penicillin, you're going to list the percent susceptible using both meningitis and non-meningitis breakpoints. And for penicillin, also indicate the percent susceptible using an oral breakpoint. Viridians group Streptococci and penicillin, you're going to list both the percent intermediate and susceptible. Quite often with Staph aureus and Enterococcus faecalis and faecium, you're going to see subsets of MRSA, methicillin-resistant Staph aureus, and vancomycin-resistant Enterococcus. They will be listed, both the organisms and the resistant organisms. And then again, the pathogen specific, and it could be all urinary and non-urinary. So we may see all Proteus mirabilis infections. We may see it broken down into urinary and non-urinary. That way, the physician is able to choose the most appropriate antibiotic to treat a urinary tract infection or non-urinary tract infection. So here is an example of an antibiogram that is broken down using Proteus mirabilis and showing all Proteus mirabilis, urinary and non-urinary. And this is going to demonstrate how the resistances can be different. So for all, we have 547 isolates. And so if we look at ampicillin in all, we have a percent susceptible of 76. But yet for our non-urinary, we have a susceptibility of 80. Amikacin, all, we have 99% for urinary, 90% and non-urinary, 100. So again, looking at your susceptibility patterns, this is going to help you determine, and especially when it's presented in this way for your institutions, based on whether it's a urinary or non-urinary infection, what is the best antibiotic to use? And again, you want to stay away from the big hitters initially to treat that infection. Those antibiotics that are generational and are known to have resistance, and we want to start out, using the antibiotics that are more successful If those are not successful at treating that particular organism, then you can escalate to the bigger guns, so to speak. So, and just a reminder that our asymptomatic bacteriuria is defined as isolation of a specific quantitative count of bacteria in an appropriately collected urine specimen from an individual with signs and symptoms, without signs and symptoms of a urinary tract infection. So we should not be treating these individuals. When we do this, this potentially leads to the development of antibiotic resistance. The treatment of asymptomatic bacteriuria is not appropriate for women premenopausal, non-pregnant, diabetes, etc. We want to make sure that we are treating a resident appropriately that has symptoms of a urinary tract infection based on our clinical presentation and the results of our urinalysis and culture. So again, collaborate with your physician to ensure that you're doing best practices. I wanted to share this, this schematic with you. This is guidance for promoting antimicrobial stewardship in long-term care facilities. And we all know that we have a problem with documentation. We want to make sure that our practices are evidence-based, that we are following the best practices outlined in our literature in antibiotic practices. So do we have recognized signs and symptoms that require treatment? Are those signs and symptoms communicated effectively? You know, nursing needs to provide accurate, timely nursing assessment. They need to be empowered to communicate that assessment, and this can be accomplished through SBAR. It needs to be informative and holistic documentation. Our physicians need to diagnose, determine the appropriate drug, dosage, duration, and consider de-escalation through a timeout, antibiotic timeout process to effectively impact and practice antimicrobial stewardship. So prescribers, we want to make sure that the antibiogram is available for the physician where he or she writes orders. So add the antibiogram to your computer-based physician order entry. Provide a copy of the antibiogram to all of your providers or prescribers. So your nurse practitioners, your PAs, and your physicians. Make them available at the cubicles where they write their orders, or make them available on their computers on wheels type thing. Just make sure that they have those copies at physician prescribing locations. So antibiograms are not generalizable to different nursing homes. The selection of empiric therapy in a particular resident should not be based solely on an antibiogram. So a patient's particular infection, their history, what antimicrobials have been used in the past, all of that needs to be considered when you're prescribing. And then antibiograms only capture the aggregate proportion of susceptible isolates for given organism antibiotic combinations. So you still need to be thoughtful about prescribing and not just solely rely on that antibiogram. Antibiograms provide guidance for empiric antibiotic use in your residence, and they also can be used to measure trends within your organization, looking at past resistancy patterns. So we've included some resources for you. The AHRQ Concise Antibiogram Toolkit. This gives you information about how to, what does an antibiogram provide, how to develop one, how to implement an antibiogram program. The APIC text, if you're a member, has antimicrobials and resistance and also explains the antibiogram in detail. And then here are 3 states that have very excellent antibiogram toolkits or antimicrobial stewardship programs for long-term care for your use. So with that, I turn this back over to Amanda.
Thanks, Christine. That concludes the slide presentation portion of our program. Now we would like to begin our question and answer period. So we do have a question that's come in here. Can an antibiogram created for inpatients and outpatients at a local hospital be used for the long-term care facility?
So thank you, Amanda. This is a yes and a no response. So depending on the size of your institution and if you're within close proximity and receiving patients from that acute care facility, there may be a need to use a combined antibiogram. So if the population within the community you serve is low and the number of residents within your facility is low, then yes, it would be appropriate to use a combined antibiogram. If you have a large facility with a large patient population with numerous isolates collected from your organization, then it is preferred that the isolates are only from your organization.
Okay, great, thank you. We did get another question here. Can PCR results be used for an antibiogram?
No, you want to utilize a culture and sensitivity. If you have PCR testing that is available that can provide you sensitivities, then that would be appropriate. But typically, you're using your culture and your sensitivity from routine microbiology culturing.
Okay, great. I think that's an important one to answer with the new technologies we're seeing coming out. So our webinar will be ending soon, but we have time for a few more questions before we end the program. And we do actually have one more that is a quick one that I think is important. Who is responsible for producing an antibiogram?
Great question. So the antibiogram is typically created by the laboratory, but it is a collaborative exercise with the infection prevention department and your pharmacy. You want to be able to go through that antibiogram, ensure that you have the appropriate number of isolates to provide accurate information. And again, if necessary, break out the MRSAs, the VREs, those high frequently occurring antibiotic resistant organisms. But it is typically initiated by the microbiology department and worked on collaboratively with your pharmacy and infection prevention departments.
Great, thank you so much. And that is where we'll end the program. I want to thank everyone for joining us today. If you have experienced any issues accessing the evaluation and/or certificate of continuing education, please feel free to direct any inquiries to Shelley Mixel at shmixell@pa.gov. This concludes our webinar.